Now you must decide if you would like to let cinch back the wire and thus retract the anterior teeth as the molar tips back, or tie it back actively, or not tie it back nor cinch it back and allow the anterior teeth to flare as the molars tip back. In this particular case, we will place an active tie back. This could be an arch wire, which in this case was going to be difficult to place. So we chose to use an elastic ligature. The elastic ligature is placed between the helix, which was made in the arch wire, and the molar hook. And this active tieback is easily replaced each month. We can also add a high pull headgear, as in this case, in order to stabilize the upper molars, to gain class 2 correction by molar distalization, and cause intrusion of the incisors with an anterior spur that is placed under the utility wire. A high pull headgear may also cause a skeletal and dental intrusion in the posterior to improve skeletal open bite. Oftentimes the molar tip back with the utility arch, however, will cause the anterior portion of the face bow to go inferior, thus being uncomfortable to the patient on the lower lip. This face bow must now be adjusted more superior on the inner bow, which is being done now with a 3-prong plier. Our next patient is back for a monthly visit with his upper utility arch. We will change the elastics as necessary and to check the activation. In this case, we ran into some tissue impingement. Oftentimes this is very difficult to change, especially if the anterior step is not accessible to the tweed plier. Trying to hold on the lateral bracket, I'm now trying to change the activation on the wire with a light wire plier. Our next patient has a lower utility arch and is back for a monthly adjustment visit. Here we will again check the activation and how the wire is secured into the molar tube. Our buccal sweeps are not impinging on the tissue, and this makes our job much easier. Removing the wire from the slots, we will find it will go down into the vestibule. This is about the amount of activation that we will get with a typical 30-degree molar tip back bend. The incisor teeth will be intruded with very light force. There will be some advancement of the incisor teeth unless you will tie back or if you cinch back the utility arch to the distal of the molar. with a cinch back or tie back, you can actually retract the incisor teeth, as opposed to allowing them to advance as you would do without the tie back or cinch back. Now we will check to see where the arch wire is placed next to the molar. In this case, I'll use an angle half plier to squeeze the loop, or to flatten the posterior step from a 90-degree angle to possibly even like a 60-degree angle. This will cause advancement of the lower anterior teeth and an increase in the tip back. I did the same adjustment on the left side, but here it seems that our posterior step is impinging on the tissue. Our arch wire is also a little bit floppy, mainly because of the advancement that's already taken place. We will first try to make the adjustment in the anterior step with a tweed plier. And possibly even trying to do it in the posterior. All of these without success in this patient. Our posterior step is still impinging on the tissue. So finally I just take an angle half plier and bend the whole buccal sweep out away from the tissue, and that seems to be successful. Let's now review some sample cases with utility arches as a part of their treatment plan.